His Excellency, the Governor of Makueni, Mutula Kilonzo Jr., Her Excellency, Madam Anita Mutula. Ladies and gentlemen, I want to invite you to Mombasa for our 48th Annual Scientific Congress. And I just want to read my small speech, my short speech. It brings me immense joy and gratitude to reflect on the past and the journey of KOGS as an organization. KOGS has celebrated momentous occasions and navigated through challenges that have tested its resilience. With the KOGS celebrating its 48th anniversary, I believe that the next phase involves not only sustaining the growth we have achieved, but also in understanding and cultivating the impact of such growth. This requires a more targeted approach, emphasizing quality over quantity and measuring success by the depths of influence and impact rather than sheer scale. Our work directly impacts the lives of women who are daughters, wives, and mothers with their own personal goals. Let's make sure that we support them to achieve their life's ambition. In this Congress, let us reflect on the guiding theme, reimagining reproductive and mental health for UHC from bench to bedside and beyond. This is in line with the WHO response to mental health promotion and prevention interventions, including care and treatment, whereby member states have committed to implementing the Comprehensive Mental Health Action Plan 2013-2030. The aims of improving mental health by strengthening effective leadership and governance, providing comprehensive, integrated, and responsive community-based care, implementing promotion and prevention strategies, and strengthening information systems, evidence, and research. I express my deepest gratitude to each one of you for increasing KOGS' positive impact through your commitment, passion, and wavering support. Together, let us move forward with a shared purpose of making KOGS an even greater force for positive change. We cannot do this alone. We have amongst us different groups and personalities who have come to support us. Right from His Excellency, the Governor of Makueni, with his wife, Her Excellency. We have the health team from Nairobi County. I think we are here, Nairobi County. We have the health team from Makueni County. I think His Excellency came with everybody from the health department. We have partners from China. I can see Professor Rose is here. Please stand and wave to us. We have colleagues who have come from other countries, from Ethiopia, from Tanzania, from Uganda, I think. And of course, we cannot forget our own members who are here. Ladies and gentlemen, without you, we cannot have KOGS. So we want to thank all of you for taking your time to come to our conference today. Thank you very much and welcome to our Congress.
Right, thank you very much, Mr. President. So once again, I'd want to invite you to invite the next speaker.
Thank you very much, Professor Bimbo. It is my great pleasure to invite today Professor Stephen Rulisa. Professor Stephen Rulisa is the chairman of the Scientific Committee of FIGO 2024-2025. Professor Rulisa is my brother-in-law. He comes from Rwanda. He has been in EXACOG, and he is a member of our societies here. And I would like to invite him to give a few words. Professor Rulisa.
Thank you. My brother-in-law is very careful so that I can't ask more cows. Your Excellency, Governor and Madam, the FIGO President, the KOGS President, all protocols observed, ladies and gentlemen, good afternoon. Before I start, I want to send my greetings from Rwanda. Greetings from Rwanda, and also greetings from FIGO and EXACOG. Thank you, KOGS, for inviting me. It's my, Kenya is my second home, almost. So it's always a pleasure to be here. So I won't take much of your time. I want to talk about two things. One is FIGO. So like as they said, I am the chair of scientific committee for FIGO, which will take place 2025 in Cape Town, South Africa. It is over a decade ago since FIGO took place in Africa. It is the first time we have a FIGO taking place in Africa, and the president is an African. And it is the first place we have the first FIGO president as a female and from Kenya. So we are not taking this very lightly. But before I go to FIGO, I'm coming back to that. Let me talk about EXACOG. How many of you know EXACOG? Just by show of hands, yeah? Okay, good. Quite a number. So EXACOG is East Central and Southern African College of OBGYN, which, well, I'm going to say the truth, is a little bit unfortunate that some of the most active members who should be most active are not really active, including KOGS. And we cannot build FIGO, we cannot be present if you are not active at home. So I want to encourage you to be members, and not only members, but active members of EXACOG. We have to build from home. So why I talk about EXACOG before FIGO, I want to tell you the link that FIGO, for the last many years, as far as I know, FIGO, I have been attending FIGO since 2008 or 9. And all the time, the biggest number of presentations come from outside Africa. And the biggest burden of disease that the FIGO is supposed to solve is from Africa. So there's a huge disconnect. Those who attend and present come from a region where we don't have the problems to be solved. So we want to change the dynamics. Now that we have the scientific chair from Africa and the FIGO president from Africa. So I want to ask you that starting very soon, the link will be open, that you submit papers to be presented. We will intentionally select papers from Africa because this is where the problem comes from. So I want to encourage you. And do you know when we came to this, when the president appointed me, and what people said, that I cannot get members of scientific committee to be on FIGO because Africans are not qualified, because they are not capable. They said, you cannot get anyone. I want to request you, my brothers and sisters, to prove these dynamics wrong in Cape Town. So I want to see you big numbers in Cape Town with papers to be presented that address our real problems, that discuss about our situations. But before that, we want to work in blocks. EXACOG is one of the main, and KOGS is one of the biggest in the region. So you should drive this agenda until FIGO. So this is my call. I think much will be talked by my president about FIGO. But I think you understand the link between Hexacog and KOG and FIGO, and KOGS should drive this agenda. So I'm looking forward to seeing you in Cape Town, and I'm looking forward to have many registration in Hexacog. We have one of our active members from Kenya. Who is Onyango? Onyango is, and Musimbi. Musimbi is from Mombasa. Musimbi is from here in Mombasa, one of the most active, but he says you don't respond to his call. Is that true? No, they say it's not true. So thank you very much for having me here, and thank you very much, and I hope to see you very soon in Cape Town. God bless you. Thank you.
Thank you very much, Professor Rulisa. We have the challenge. 2025, we have to have as many papers in FIGO as possible. We cannot work alone. We have the union with us, the Kenya Medical Practitioners and Dentists Union. We have the Secretary General. I would like to invite Dr. Davji Bimji here to give 1 or 2 words. Thank you.
Comrades, power. Comrades, power. Comrades, power. Before I start speaking, I will ask all the union leaders, and if you are a union leader, it means you served in the union from 2010 at the inception to date, to kindly stand up. Yeah. Thank you. So, ladies and gentlemen, Your Excellency, the Governor, the President for FIGO, and all the protocols, I must say that I did not know why KOGS organizing committee decided to make it on this particular day when we are supposed to be our loved ones. But I was discussing it with my wife last week when I received the letter, and I told her that if there's no love, then probably 99% of those who are in this room will be jobless. And therefore, it is very important to note that in the next 9 months, there'll be a lot of windfall for work. So I am really happy to be in this particular gathering, given the nature of the environment that we are operating in, that has many things to deal with the matters of labor. I'm not talking about labor in the wards. I'm talking about the real labor, but the disputes could be the same. And I must also say that I'm so happy to find that almost 90%, if not 99%, of the people in this room are actually leaders in various places. The DG of this country is from this particular organization, the CEO of KMPDC, the president of KMA, my own deputy, and I can also see the director from Nakuru County, even the director from MOH. So it's very clear that the leadership in different positions in healthcare actually come from KOGS. Why? Because your roles are to deliver, and you actually work to deliver results. And John Quincy Adams says that a leader is somebody who is able to inspire you to do more, to learn more, to dream more, and to become more. And I believe that's the reason why we're here. Because without that, then there's no possibility to be a leader. We have a lot of issues in healthcare that actually requires a concerted effort. There are a lot of challenges that are coming up that if we go and sit down and say we are professionals, then the policies that are going to be made will be purely extractive. And we must say that extractive political ideas result into extractive economic ideas or economic policies, which means we will turn out to be beggars. You may have gone for medical school for 7 years and do another 7 years in Obstetrical like Ms. Keller, but you will be forced to beg especially if you go and ensure that you're not part of the policies that are being made. Why am I saying this? Because there's one particular act that has come up called the Social Health Insurance Fund. I know most people a lot of times don't read, and it's out of this ignorance that political class will actually take it to control and make things to your disadvantage. We had a very heart-to-heart discussion with the Council of Governors, and we were having a talk with the chair of the Health Committee and the chair of Labour Committee. We had a 5-hour meeting one evening when this was still a bill. And afterward it became an act. And then we realized that this act, this shift, is going to destroy public health care. Why am I saying this? Because in this country, they talk about universal health care. They talk about the primary health care. It is only that way that national comes in to contribute and be part of it when donors are giving out money. But when now we're talking about the primary health care fund, it has been put such that the level 1 facility in Makweli, the level 2 facility in Turkana, the level 3 facilities are to compete hand in hand with Bliss and Life Care for the same exchequer money. There is no possibility that that will happen. We have come out to say that this particular shift is going to be more extractive because there's more focus on taxing and exploiting more of the salaried monies without the package that people are going to have. There's more that you're being told that as a worker, regardless whether you're in private sector or wherever you are working, you'll have to again get a private insurance to get care. So therefore, what is it meant for? There's also clear empanelment that has been put in place that they are now trying to put it out of the KMPDC to give a different paneling. And I must say, it is paneling that has been used to actually make healthcare difficult. It is through paneling that today you've gone to school for 14 years and SHIF or any other institution, any other private insurance like MKL will say, no, they're removing you from the paneling and you are out to beg. This happens if you don't come out and say, no, we must ensure that we are part of the process and it's able to actually take care of all the service providers. It must be able to take care of the workers. It must be able to take care of the population. Because with the shift the way it is currently drafted as an act, it will not. I may say this confidently, but you will see in the coming days that the drafters and the way it is going to be implemented with the facilities we have in the counties, with the nature that it has, is going to benefit a few clique of individuals that are drafting it. So we must rise up as KOGS, because this is very key, given that the biggest indicator of health system in a country is the maternal health, is the neonatal health. We have seen the removal of Linda Mama. I'm here to see, and we want, as KMPDU, to join you in saying the double increase in number of mothers who are going to the facility to get care. What will happen to them? We want to get the data that will actually be used to make sure that the packages that are put up are able to do better than what Linda Mama was doing. But if it's just removed, I can tell you more of the jobs that we are doing will go to nothing. And I'm saying this also when I have data that the government has not paid facilities over 15 billion. Particularly in Kenyatta National Hospital has only paid 1.5 billion for Linda Mama since last year, February. Same to all the facilities across the country, both public and private. So how is the government going to give us universal health care if they can't disperse funds to these facilities? We must ask ourselves that. I must come to the next issue that really need a concerted effort. And this is a constitutional matter that I am so sure the governor understands. And this is a matter of e-teams. It may look far-fetched. It may look far-fetched. It's a matter that we are trying to take to tribunal, but we realized that it's a constitutional matter. It's going to deny you as a doctor, as a consultant, the right to see a patient and to give them the care. Because how will you see a patient, give them a care, and wait for 10 months, 10 years, or 3 years to be paid by insurance, yet you pay the tax? It will deny the patients the ability to access care, because then they'll have to pay you in cash so that you can do the returns in cash. So we must come out very strongly because it's a constitutional matter, and we are having discussions to actually take it to constitutional court, because most of the time, when we beg the government, when we beg the institutions, they will not listen. We have to take action and really know our value and our dignity. I must also put it clearly regarding the consultancy. We know the lawyers, the architects, the accountants, and all the professionals have a withholding tax of 5%. Today, KRA has slammed KNH with 800 million on the consultancy services that were offered by the consultants. The same has happened in MTRH. The same will happen to you. So if they want you to have a withholding and increasing taxes on your part, it is very key for the government to know that we will add those taxes to the services, so that the cost of care will not be upon the doctor, but it will be upon the government to know that the taxes that are put is what is increasing the cost of care. These are very, very important things that we must unite and see how to push back. It will take all our efforts to do this. I must also say, given that the governor is here, that we may go on strike in the month of June. And the strike that is coming is quite imminent, and it may not be stopped. Given that we have the national government, who has about 1.5 billion from the CBA that was signed in 2017, 2021, that you, Governor, helped us along to get it. And I think that's why you are a doctor today. So we must say that we are going to go on strike for this, because we've been having discussion and negotiation for 1 year. And I believe many of the doctors who work in the public sector particularly have been checking, and they know how much they are owed, from 300,000 to 500,000. Sometimes for government to pay this, they must be forced to do it. There must be some level of duress for it to be done. We are also discussing the CBA 2021-2025, which I must reiterate that we don't want salary increase. We just want that the consumer price index and the inflation of the period, which is at 50%, to be considered. For that to happen, despite it being an inflation, we'll have to force the government. I must also say that we are asking the governors to man up. We are asking the Council of Governors and the governors to actually stop having shells in the hospitals in the name of facilities. Why am I saying this? The national government has taken it upon itself to reduce the financing the counties. It was 15%. It was then 13%. In last financial year, it was 9.8%. When the governor keep thinking about the future, how they want to be appointed to be ministers after serving the second term, how they want to go to other political positions, so they have to preserve themselves, then we are going to have budget to counties at 3%. Then we are told health is devolved. You have to employ human resource. Otherwise, we will not have any functional health care. So our demand, which we are in a strong way trying to make governors as our alliances, that as it is, before we get Health Service Commission, if it is to be there, we want at least 20% of the budget to actually go to counties, so that this, I would say, nonsense that we keep on getting, that the wage bill has been exceeded, that the counties have surpassed the ceiling point of the PFM Act, that have gone beyond 35%, and no county can employ, yet counties are to offer services. It won't be possible. This has to come out, and this is only possible if the governor step down and say, we need the funds, and as a union, we will come out very strongly in the same manner, because we need doctors employed. I must also say that we have had a discussion with the Council of Governors, and one thing that we keep reiterating, that it is not possible for the ministry, and I know my brother Kigen is here and he's going to get the message down very well, that they keep on having the bigger budget, over 150 billion, and we have postgraduates that are not being paid their salaries or being paid from the counties. That the fees we have to push every time by demonstrating, that we have to go on the streets for the interns to be posted. The ministry must actually prioritize the issue of training. And what I'm saying is that we really need to have the postgraduate doctors being paid from the ministry, so that the money that is left behind is ring-fenced for the counties to actually employ more doctors. So doctors, I'm saying, and this is very clear to us, that we must unite. The enemy is not within. Our internal wrangles may be very mild, but they should not be put to an external body to arbitrate. Mostly, it gives the oppressor the leeway, the capitalist the leeway to oppress you more. We have experienced this in 2 years in KMPDU, and we will not wish for any organization, be it KOGS, be it KMA, or be it any other, to feel like they have to go the same direction. We must sit down and look to it that what is this interest that we have, that it is me has to be the leader. We must say that we are all for our own interest, the interest of the profession, and that calls for a talk that will ensure that professions actually grow. Because in any fragmentation, I must say this, the winner is the oppressor. And this we have to look in totality. KOGS must come out strongly to form alliances with the civil societies, to do researches that can be shared with us as a union, to actually make noise if necessary, to actually go to the street if necessary, because if we go to the street, if the same doctors will be on the street, so that the objective of a patient care can actually be achieved. We need solidarity. We need to see to it that the data that is shared from KMPDC, where of the 100% doctors who are taken there for medical negligence, and I must say this with a lot of pain, because in December, there are 2 doctors who are to be sentenced on 27th. We had to rush to court against that particular sentencing order and get an injunction. And this was because at Mama Lucy, they did not have the equipment and the drugs to take care of the patients. So they actually lose the patients. When that happens, the first point of blame is the doctor. But in analysis that has been done by KMPDC, that 80% of the medical negligences that are reported are system problems. It is the county who does not have the drug, there are no equipment, and there's no possibility for any doctor, even if you import them from where, to get this care. So we must come out and stand firm the way the doctors in Kakamega did. We must come out and close the facilities when you know that your role is just to supervise death in those facilities. And this can only happen when we come out with solidarity. Solidarity of purpose, and solidarity that will ensure that we stand for each other. And solidarity is an authentic moral virtue. It is not a rogue compassion or shadow distress at the misfortune of many, both near and far. But in contrary, solidarity is a firm determination and perseverance to determine that oneself stand for that which is common to all. That's what we stand for, and that's what every doctor in KOGS and every doctor in the country need to stand for. Thank you, and God bless KOGS.
Thank you very much, Secretary General. My hope and my wish is that all that you have spoken about will come to pass, and that doctors will be stronger, and there'll be solidarity, and life will be better for all of us, not only for all of us, but also for our patients as well, because we are here for our patients and also for ourselves. She's not a stranger to us. She's a teacher, she's a mentor, she's a farmer, she's a mother. She wears very many hats. She is one of us who has traversed and has ascended through the different levels of leadership. And now she sits at the pinnacle of leadership of our organization. And I'm talking about Professor ABC, as we call her fondly, Professor Anne Beatrice Kihara. Professor Anne Beatrice Kihara, we are privileged and we are happy that for the first time we have from Sub-Saharan Africa and a lady and the youngest president of FIGO. Madam President, in October 2023 in Paris, you were inaugurated as the first African president of FIGO from Sub-Saharan Africa. And in this event, you are actually carrying the dreams and the aspirations of not only Kenya, but the whole of the continent of Africa on your shoulders. Madam President, you know that our indicators are not good at all. Our indicators right from teenage pregnancies, FGM rates, maternal mortality rates, reproductive cancers, and so on and so forth. It is our hope that as you sit at the helm of FIGO, we pray that through your good office and through our professional organizations, we shall be able to have collaborations, projects, grants, and so on, which will enable any and every obstetrician, right from Nairobi to Mandera to Migori, to whichever area that we are in, which will help other healthcare workers, the midwives, the clinical officers, and so on, in the so-called last mile, to be able to apply technologies which will have an impact on our indicators and our outcomes. We have talked about our maternal mortality rates. We have had our pre-Congress workshops. In the morning, we had a beautiful PPH plenary session. And we are looking at you. We are looking at you. And as we look at you, we also pray for you, because we know you have a difficult task, but with that difficult task, you are not alone. We are here to support you. Madam President of FIGO, welcome.
Thank you, Dr. Kireki. Good afternoon, everybody. Good afternoon. For the sake of my unionists, I'm now putting on the glasses. We have a very serious agenda. Your Excellency, Bwana Governor of Makueni County, Madam Excellency, KOGS leadership, I can see you all around, Ministry of Health well represented here, our chief keynote speaker, and our union representative, the donor community partners, colleagues, good afternoon. I will start at the very beginning by recognizing KOGS is not alone. Kenya is not alone. And I will ask all the FIGO members who are here, representing different nations, starting with Rulisa, who's from Rwanda, please just stand up. Please stand up, Rosie. Stand up, FIGO members that are here. Stand up, Nigeria, you're here. Tanzania, sit down. And thank you. The reason I'm actually asking them to stand up is I think you'd recognize from last year, the first thing I started doing was expanding our reach. We have to get twinned as KOGS with the global community. And this is what I've written down. There is no tool, and I want everybody to mark the words, there is no tool for development greater than the empowerment of women. Greater than the empowerment of women. Your Excellency, this morning you really attested to it. They are the most significant. You, as the obstetrician and gynecologist, have really been given an enormous task to make sure every woman not only survives, she thrives. And we can then transform nations. KMPDU, unless you rally with the women, your voice will not reach the end. We know where the shoe bites. When you have unhealthy children, unfed children, no money in the basket in the home, and yet I still have to clothe, I still have to give food, I still have to give shelter. There is a humongous task ahead for all of us. That quote was actually said by the late Kofi Annan. And we are the guardians. That is why obstetricians and gynecologists are becoming more political. We're beginning to recognize we can't just sit and fix patients. We are the guardians. And I want to put it into context, related to the global ecosystem that is current. We have geopolitical polarizations, climate change that is happening, environmental pollutants and toxins, and we know that's affecting our babies when I'm pregnant. Dwindling natural resources. You don't have to go far. Look at just water, the quality of the soil, and the air we breathe. And emergent diseases. We've just come from COVID, but we had others, Zika, Ebola, and others that are there. But imagine this is compounded, Your Excellency, on communicable diseases and non-communicable diseases. We haven't even tackled those, and we're having other things coming in our space. The West is the socio-economic downturn. The gynecologists will not speak, but I can speak for them. Our practices used to be robust. That's not happening. Why? The buying power of every Kenyan is crying for help. That's our reality. And if you can't get basics for food, how much will you be left to give to healthcare? Yes, we may be moving into primary healthcare, health promotion and preventive strategies. We may be remodeling our healthcare services for curative, doing procedures that do not keep patients in a hospital. But in the first place, am I able to get there? Do I have the insurance? Do I have the transport? Do I have the decision making in my hands as a woman? That notwithstanding, we have a good backdrop. And I say this very positively. We must, and particularly in Africa, embrace technology. We had that conversation earlier on, where we're saying, become more efficacious. I bleed when I still see we're not even on a digital system in all hospitals. There's no way you can talk about research and what is contextually for your county or for your region. And as if that's not enough, I've been privileged to travel to China and see the way they've embraced technology, not just for digitalization, but for even data repositories and technologies. If there's one lecture I want you all to come to, it's the one happening on digitalization and the one that will be told to us by the HIFU team. Rosie, thank you for giving us that expose. We must use technology. We must begin to talk as a multi-sector. We're still talking to ourselves, ladies and gentlemen, as health. We don't talk even to our lawyers who are here, with His Excellency here. We don't talk to agriculture. We don't talk to education. We don't even talk to finance, let alone to our chief guest speech on mental health. Our doctors dying, and particularly junior doctors, just giving up and killing themselves. Why aren't we expanding our portfolio? We have that opportunity. The other thing that I want to talk about is embracing of what I call a reimagined healthcare system. A reimagined one, because I've belabored and thought about it many, many times. And I will start with the top, our leadership and governance. Most of us are just technocrats. You work mechanically in your hospitals, be it public, private, faith-based. The question is, who is bringing out that voice? Who is agitating when a health system is failing us? When we have to see teenage mothers still happening. And the backdrop of a teenage mother is this: sexually transmitted infections, HIV, top. gender-based violence, and the risk downhill of oncological malignancies. Can we make that difference? Where is your leadership and my leadership? I cannot work in Africa alone. I cannot work globally alone. I've got to work with each one of you. The second thing is setting our agenda. In fact, every time I go to meetings, and Rulisa knows this, I tell them, where is Africa? Where is LMICs? So I'm looking at Southern Asia, I'm looking at Latin America, because they're similar to us. But we must set our agenda. I was categorical. When I took leadership, it's going to be PPH. If there's anything I'm going to add on top of PPH, it'll be cervical cancer. Because those are the two elephants we must tackle. And you can't do this if I'm not talking in country. And this is where I look at the professional society. It's not about me. The professional society must step up engagement, both with the counties, because we're in a decentralized system, and with the country, and particularly and most importantly, collaborate with Ministry of Health and other partners. We have the expose, we will bring that we can, but we also must do our bit. That's the only way I will say we'll be respecting the sovereignty of our nation in the long haul. The second thing is collaboration that is mutually based on trust. A lot of strategic partners are getting colder and colder feet. Money is less amongst donor communities. When we talk of stepping up your domestic funding, do I trust the person I am going to partner with to deliver? We must think. Africa is well known. Corruption exists. Deliveries are minimum. And people are scared. But you can change it. We can change it if we're talking from the front. The second thing is, how do we design our programs? How do we get programs well coordinated and orchestrated? Not for what I call projectosis. Projectosis is a quick fix. You come in, Your Excellency, you give me a project. I'll do it for 3 years. There's no institutionalization. Once I leave, we're done. That is not what the Kenyan woman needs. She needs a consistent pick up and fly off, scale up, sustainable. So we've got to have a reimagined think. When you do take on these projects, ask only one question. Let me tell His Excellency what it is. What is the sustainability? What is the scalability? That's it. If somebody doesn't come with that agenda, don't give them anything in Makueni. Number 2, context. What I need to do in Makueni is different from what I may need to do in Western Kenya, and may be different from what I need to do in Central and the Northern Frontier. But have we even belabored in our counties to know what is my priority agenda? And stick to that. The third in programming is strengthening the capacity. My unionist has spoke about it. Competencies of the clinician. I want to add one word: fit for purpose. Are we just rolling out? I have people here in the academic field and researchers. But are you fit for purpose? Or should you go home knowing what the globe is actually dictating for us? And then, the one you're belaboring too, as I listen to you, is the iniquities and managing of power asymmetries. And this starts right from our political dispensation. Where is our voice? Where is our agency? How can we plug even into your system? I think we had this conversation even earlier. So that you, as gynecologists, are seen and heard. Not quiet. We've got to agitate everybody. Number 2, the financing modeling in health. The human resource modeling in health. The partnership in health. And I will end with this saying, global challenges certainly need local solutions. And we must address inequalities of gender and iniquities associated with that. We must address global insecurity, and I'll even say localized insecurities. Right now we are being shaken as the health sector. But how are we addressing it? Poverty anywhere is a threat to national prosperity. We must also address greening. So when I say greening, people will ask, what have we got to do with environment as gynecologists? You should be at the forefront. And yes, FIGO is trying. We have the Leadership Development Initiative, REACH. But it's not enough. You have to play your part. And we need to rally together with midwives, with clinical officers, and other disciplines. But I want to leave my last parting shot, particularly addressing the women in this house. We've been too quiet, too long. We've got to wake up as mothers, as sisters, as aunties, as friends, as professionals who know where that shoe bites worst. Let's rally together, walk together, but above all, act together.
Thank you very much, Madam President. Nobody puts it better than you do. We want to thank you, and we are privileged, as I said, for you to be at the pinnacle of our societies, our federation, and we are glad that you're here with us. And we have to do this together. I'd like to invite Dr. Marjan, who is the chairman of the Coast Branch, to come and say a few words and invite us to Mombasa. Karibu, Dr. Marjan, please.
Thank you very much, Mr. President of KOGS. And I will also recognize the chair of the Scientific Committee of FIGO, Professor Rulisa, and the chairman of FIGO, Professor ABC, and also the governor of Makueni, the second governor. And also he was the first senator. He was the second senator after the late father. I want to say this about cost, particularly the KOGS. For a long time, KOGS had a green book, and branch was mentioned there. And nobody wanted to put the finger on the line until the Mombasa veterans led by Dr. Kirima and other senior people and Professor Rafik Paka went to Eldoret in 1998, and we said we have to establish a branch of KOGS. So KOGS Coast became the first branch, and we have taken it from there. I wish to remind all of us, before the launch of KOGS in Rwanda in 2017, we were there with Professor. There used to be KOGS, which meant the association which brought all the East and Central societies of East and Central Africa in obstetrics and gynecology. Mombasa, after holding the first KOGS conference in 1998, held the first, the first EXA-KOGS conference in East and Central Africa in Mombasa in the year 2000, and was followed that again in 2009. I must say, with the help and assistance of members, I believe this is one of the most active members and contributing a lot to the membership of KOGS. I think we are going to discuss this in our AGM. The 56 or so gynecologists in this region are all paid up members of KOGS. Please give them a very hearty clap. I wish to recognize, would the members, KOGS branch members stand up? I can see these are just some of them, but in between, as we are handing over the baton, you notice that today Dr. Nasser read the prayers. My very able Vice Chair is Dr. Mitei, and then we have our secretary there, Dr. Musimbi, and the committee member there, Dr. Kapanga. These are the people that I can recognize in the crowd. But I must say, having said all that, I'm very happy for the national office to entrust us with holding this conference after the COVID-19. We've been holding it successively here, and everybody is very happy. Welcome to Mombasa. It has been a very beautiful day and sunny day. Enjoy yourself while you are here. The beautiful beaches and the beautiful parks which are very close by here, Amboseli and Savo. Karibuni nyote, asanteni.
Thank you very much, Dr. Marichan. And we are happy we're in Mombasa. We are happy and we'll make use of the beaches, as you've said, and enjoy the sun and the sea. KOGS does not work alone. KOGS works with partners, some of them who are local, some of them who are international. And today we are privileged to have the UNICEF representative here, and that is Dr. Laura Oyengo, who is representing UNICEF Country Director. And we'd like to invite you to give you a speech. Welcome, Dr. Laura.
Good afternoon, everyone. Cabinet Secretary, Ministry of Health, represented by Dr. Bashir Isaac. Governor, Makueni County, His Excellency Mutula Kilonzo Jr. First Lady of Makueni County, Her Excellency Anita Mutula. FIGO President, our own, Dr. Anne Kihara. FIGO Chairperson of Scientific Committee, Professor Stephen Rulisa. I stand on existing protocols, distinguished guests, ladies and gentlemen, all protocols observed. Good afternoon once more. As it has been spoken today, I'm here on behalf of the UNICEF Kenya Country Office Representative, Shaheen Nilofa, and I will read the official remarks on her behalf. It is an honor to be here with you all today at this auspicious conference by the Kenya Obstetrical Gynaecological Society, themed Reimagining Reproductive and Mental Health for UHC, from bench to bedside and beyond. Kenya has demonstrated its commendable commitment towards UHC. Just recently, 4 bills were signed by His Excellency, the President of the Republic of Kenya, and this commendable commitment will allow all citizens of this country to access health care. But we also need to remember the success of universal health coverage hinges on the health outcomes. And for optimal health outcomes, the country needs to make a concerted effort to improve the quality of care. And none so more important for the mother. And we cannot talk about the mother and leave the baby out. When we focus on maternal and newborn health, our statistics have shown us impressive coverage. The recently released Kenya Demographic Health Survey 2022, it showed that 98% of the women receive at least one antenatal care visit. 72% come for postnatal delivery, and 89% actually deliver in a facility. However, these are the national averages. As UNICEF, we work in the most remote parts of this country, in the arid and semi-arid lands. We work in urban informal settlements where we see significant variations within and between the counties. For a woman living in Turkana, in Mandera, in Samburu, in Tana River, is not the same experience of care like a woman who is in Nairobi or Mombasa. Coverage for crucial reproductive and maternal health indicators in these counties is far below the national average, and it highlights disparities in access to health care. As we scale up UHC, it has to go hand in hand with quality of care. And when we talk about quality of care, it's the degree to which health services for individuals and populations increase the likelihood of the desired health outcome. That would mean when a mother comes to you during pregnancy, what they desire is an uneventful labor and delivery, and then a healthy baby and a mother afterwards. It also means that a woman has a choice for their reproductive health services, and that the mother and baby survive, thrive, and live to their full potential. Even with these impressive coverages that I've spoken about, when we now look at the data for Kenya, as per the 2019 census, we find that the maternal mortality ratio is 355 per 100,000 live births. When you look at the newborn mortality, this is from KDHS 2022, 21 newborns per 1,000 die in this country. Majority of these deaths are preventable, and they can be averted just by improving the quality of care. As UNICEF, we look at the local data, we look at the local reports. The most recent report that was done was the National Health Facility Census. This was done in September 2023. And what this report underscored was that there were substantial gaps in availability of skilled health providers, shortages of equipment and supplies in maternities and newborn. And there was a very passionate plea from KMPDC. You don't want to go to the facilities to sign death certificates. You want the equipment and the supplies to take care of mothers. Ladies and gentlemen, I think every speaker here has touched on teenage pregnancies, and there is a reason. Kenya has a teenage pregnancy rate of 15%, and this is from the Kenya Demographic Health Survey. Bwana Governor, in your county, it is 11%, and it means around 1 to 1.5 of every 10 women in this country who's pregnant is a teenager. When you look at counties, contextualizing it, it's not the same for counties like Samburu. The teenage pregnancy rate in Samburu is 50%. Half of all women in Samburu who are pregnant are teenagers. These are young girls. In their young age, they are not psychologically prepared to take care of themselves or a baby. They have schooling to think about. They have their whole life ahead to think about. They face stigma. How do they reintegrate back to society? It is a unique population who require mental health support as part of any routine care provided to them when they are pregnant, after pregnancy, and beyond. As UNICEF, we are delighted to work in partnerships both with Ministry of Health, with the Kenya Medical Professional Associations, the various ones. Want to thank Dr. Kireki and also Professor Obimbo who approached us seeking partnerships. It's by these synergistic efforts and working together that we address these mortality rates. However, this is our work at national level. At subnational level is where rubber meets the road. It's where we work with you clinicians individually. That's where the woman meets the health systems and receives the health services. We look at the arid and semi-arid lands, as I said, and the urban informal settlements. And for us, what is important is to look at the capacity of healthcare workers and to ensure they receive training as recommended by Ministry of Health. We also support procurement and installation of newborn and maternal health equipment, especially in these remote places. Beyond health, we ensure availability of water and sanitation facilities in newborn and maternal health facilities or units, and also we support in solarization of energy sources in those facilities so they don't have power interruption. Mental health is important to us, and currently we are working a journey with the Ministry of Health. We are looking at how mental health can be integrated into the continuum of care package for pregnant women. However, we have a special attention and focus to the pregnant adolescent girls, given their special needs and increased vulnerabilities. We also look at the wider system. We look at the communities. How do we engage communities? How do we engage leaders? How do you engage activists, religious leaders, traditional leaders, who are the voice of the communities and who are the change makers in areas where you don't reach? I would like to take this opportunity to commend the Ministry of Health for providing their visionary leadership in scaling up UHC. We are firmly behind you. And also in ensuring reproductive, maternal, and newborn health is one of the pillars for UHC. I will also take this opportunity to commend KOGS for their advocacy role in championing the health of women and babies. The message came clear to us. PPH is paramount, and that's what we are focusing on. So we are going to be working together. As I conclude, I'd like to leave with you these messages. All women and newborns in Kenya, they deserve the highest level of quality of care, irrespective of where they are, and their lives count and should be accounted for. We need to ensure that maternal and newborn health remains a pillar of UHC. The president of FIGO has said, where is our voice? Where is your voice as the obstetricians and gynecologists? And you ensure no one is left behind as UHC is scaled up. More so for the women and newborns from the most vulnerable populations, including adolescent girls. We need to understand that adolescent pregnancies increase the likelihood of maternal and newborn mortality. They also increase the likelihood of mental stress for these young adolescents, school dropouts, and they further enhance the intergenerational poverty cycles. So we should all join hands in changing societal norms and root causes that are drivers of teenage pregnancies. And finally, I was happy when I heard the president say this: we need to empower women and adolescent girls. We need to give them a voice to shape the healthcare and education they receive as per their need. Distinguished guests, UNICEF reaffirms its commitment to continuously working with the Ministry of Health, counties, other UN agencies, other health and developmental partners, medical professional bodies, to continue improving the health outcomes and well-being for all women, babies, children, and adolescents. I want to say thank you, but I also want to wish you all a happy Valentine's. Asanteni.
Thank you very much, Dr. Laura. We'll have a short entertainment session for 5 minutes. Kindly, let's have our dancers.